good morning. Welcome to this meeting of the Health and Wellbeing Board, and I'm Councillor Graham Bridgman. I'm Chairman of the Board. As usual, this meeting is being held in a hybrid format with some of the board members in the room being a quorum, and some of the board members attending virtually, and one of the presenters in the room, welcome Alex, and other presenters attending virtually. So joining me in the temporary chamber within Market Street in Newbury are the Vice Chairman, Dr. Abid Irfan, Councillors Lynn Doherty, Martha Vickers, Steve Masters. We also have Sean Murphy and Gary Paulson from the Volunteer Centre and the Public Protection Partnership, irrespectively. I had that round the wrong way. And Matt Pearce, who is Service Director for this area of the work of the Council. I think we are expecting Emily Evans from Thames Valley Police, but maybe not in the room. Other members attending virtually and substitutes are Councillors Rick Jones, Joe Stewart, plus Paul Coe, I think probably substituting Gail Muirhead, Andrew Sharp, Reva Stewart. I don't know if I've missed anyone out, and apologies if I have. We're going to welcome, as I say, Dr. Alex Evans and Leila Johansson and Matt Tate, who are all presenting items on today's agenda. And because Alex and Matt both need to leave early, I'm going to move their items up the agenda when we get to that point. Those present in the chamber are, as always, socially distanced and sitting with masks removed. We're, as always, live streaming this meeting to YouTube, and so members of the public can follow what's happening. Gordon Oliver is acting as clerk for the meeting, and Stephen Chard is acting as Zoom host. Now, as members will know, but just to clarify for any member of the public watching, when we come to a vote, because this is a committee of the council and there is some formality, only the members of the board in the room, physically in the room, are able to vote on an item. But what I will do is, where we do have any vote to be taken, I will look for a virtual vote in the usual way by using Zoom hands to vote for all members, including those in the room and those attending virtually. And then I will look for a show of hands physically in the room. Finally, before we move on to the agenda, this being a Thursday and this being Market Street, there is going to be a fire alarm and a lockdown alarm around about 10 a.m. So if we're speaking in the chamber, we'll probably have to mute ourselves for a couple of moments while that passes. So item 1 on the agenda is apologies for absence. So I'll ask Gordon whether we have had any apologies. Gordon.
Yes, Chairman, we have apologies from Superintendent Zahid Aziz, and I believe Emily Evans is supposed to be substituting, from Tracy Nashkovich, and from Katie Summers, and Joe Reeves is substituting for her.
Thanks, Gordon. Anyone else has any apologies to propose? No. Second item on the agenda is the minutes of the previous meeting. That's the minutes of the meeting on the 9th of December. I have one very slight amendment to propose from the chair, and then I'll see whether anyone else has any amendments. It is simply to say, and I know that this is not Gordon's fault, it's a product of the software we're using, because the software was designed in an age before remote meetings, so it doesn't actually understand the distinction between those who are present in attendance remotely, i.e. members of the board in attendance remotely, and those who are also present. It shows Councillor Rick Jones as, quote, also present, but of course he was actually attending as a substitute, so he should be in attendance remotely band. Minor amendment, as I say. Are there any other amendments that anyone would want to suggest? No. So I won't look for a virtual vote on this one. I will simply look for members of the meeting who are either at or wish to vote on this item at the last meeting to say yay or nay to the minutes. I'm proposing them from the chair. I thought Councillor Doherty might second them. All those in favour? And I think that is unanimous. So thank you, members. Welcome, Emily, and we'll let you get set up. So, moving on. Actions arising from the previous minutes. Now, members, you have a list of actions and what is happening on those actions in your papers. I won't go through the specific items individually. I'll just make a couple of comments and then look to see if anyone else has anything they want to raise. On item 153, that is the peer review, just to say that there is work ongoing in relation to the peer review. Certainly we are looking at the question of the contract with the LGA and so on and so forth. And the biggest challenge is actually going to be scheduling meetings between ourselves and any peer review team. The key piece of advice we've received from the LGA thus far is that the longer lead time we put into this piece of work, the better. And they were advising a minimum of 6 months. So be aware that this is not something that's going to happen tomorrow, but it is certainly something we are progressing and will move towards. I don't think there's anything else I want to raise specifically from the chair, except to say that I suspect that items 180 through to 183, which are to do with continuing healthcare and the CCG, will probably be picked up when we look at the forward plan, because there is an item on the forward plan for May in relation to that. So now to see anyone else. Councillor Bowie.
Thank you, Chairman. In the minutes, item 64, Health Watch report on CAMS. I wasn't able to attend the last board meeting, but members resolved to endorse the report's recommendations and ask key partners to act upon the report's recommendations. Prior to that, Matt Pearce had said that he thought that he indicated that the minute says that the action on this going forward would be taken up by the Children's Delivery Group. There's no action resulting from this item number 64. And as far as I know, there has been no, let's just say that at the moment, the Children's Delivery Group is not aware that they're picking up the delivery of the recommendations that Health Watch report brought forward.
Thanks for that. I'll bring in Andy in case this is on the same point.
Thank you. It is on the same point. I just wonder whether there might have been a bit of confusion about which group is picking things up. We've got an ICP delivery group for children's, which is taking forward a project around CAMS and mental health and wellbeing. I don't know whether it was actually that group was going to pick that piece of work up around the outcome of the report rather than Delivery Group Health and Wellbeing Board. I might be wrong, but that could be the reason why it's not picked up, as Dominica suggested.
Right. Can I leave Councillor Bowick and Andy and Matt and Gordon to work out between them what should be listed as an action arising, who should be dealing with it, and make sure it's embedded as necessary in the list of actions arising. So I'll leave that to member and officers to sort out between themselves. Just also to say, members, that Andy has reminded me that Andy Sharp, that he is only here for the first hour. So at that point, when he departs, Paul will be in his place as substitute. Paul is, of course, already in the meeting. Okay, so I see no further hands on that item on the agenda. So we move on to declarations of interest. There are, as always, the two standing declarations on the agenda papers. So I just look around to see whether anyone has any other declarations they wish to make for this meeting. No, we move on. So next is public questions, and I don't believe there have been any, Gordon.
No, we haven't had any questions at all.
So we move on again to petitions. Again, I'm not aware of any petitions having been submitted. Gordon, are there any petitions submitted? And then I'll look to members if they have any.
No petitions received, Chairman.
And I look to members to see whether they have got any petitions they wish to present. I see not. So again, we move on. So, members, we now move on to the meat of the Health and Wellbeing Board's meeting. And as I said, I'm going to move a couple of items up the agenda. I'm going to move item 11 next. That is Royal Berkshire Hospital Winter Plan Update. Then I'm going to move on to item 10, which is Integrated Care Systems. So, welcoming Dr. Alex Evans, who is a consultant hepatologist and network care director for Royal Berks, to the meeting. I'll hand over to him to present item 11.
Can you hear me now? How's that? That's better. Okay, thank you very much, Chairman. I'll just now try and share my screen. And great. Okay. I'm just going to give you a quick update on the current situation at the Royal Berkshire Hospital, just what we're doing and the challenges that we're facing. Very happy to take any questions on any issue. Currently, the situation at the Royal Berks regarding COVID, we've got 109 positive COVID inpatients being treated in the hospital today. We've got 3 on the intensive care unit, one of whom is ventilated, 2 of whom are receiving non-invasive ventilation. And we have 3 other patients receiving non-invasive ventilation on the respiratory ward, Kennet ward. We have about 40 COVID positive patients who are treated on a virtual ward, so they have daily contact with the physicians at the hospital and they monitor their oxygen levels and symptoms at home and come in should they need to. The impact of that burden is much less than the second wave, where we had over 280 patients at the trust. The main impact is on managing the flow of patients in and out of the hospital, because obviously we need to keep patients with COVID separate from those who don't have COVID. And we've done that very well. We're one of the top trusts in avoiding nosocomial infections, but it does obviously put additional stress on the hospital. In anticipation of the question, there is a disproportionate number of the inpatients are not vaccinated or aren't fully vaccinated. So all of those patients currently on the intensive care unit.
Sorry to interrupt your flow, but what you're presenting isn't presenting to everybody else.
Oh dear.
Okay. Stop. Yep. Yeah, if you just
I'll leave it at that.
and if you just click on that little button there.
I did that last time, and that's when it
Oh,
didn't move on.
All right.
Yeah.
We'll
So we'll leave it like that. Thank you. So yes, the disproportionate number of the inpatients are not fully vaccinated. All of the ITU patients and the majority of those patients currently requiring oxygen or ventilatory support are partly or unvaccinated. So really important to keep driving that message home of how important the vaccine is in avoiding a serious illness. We've got a high uptake of COVID vaccination amongst our staff. So we're on 96.3% of our staff, 13th out of 216 trusts in England. And in terms of staff sickness, it's a little better than it was. We've got approximately 150 out of over 6,000 staff currently off, either with COVID or having been exposed to a close contact. And the teams are really working well and working hard to overcome those staff sicknesses. In terms of the challenges that we're facing at the moment, there's very, very high pressures on our emergency department. So we're getting, not unusually, over 400 patients a day attending ED. Just a couple of years ago, pre-COVID, that number on a bad winter's day would be around 300. So we're talking about a 33% increase. And we clearly haven't had a 33% increase in staff or space. So that's been a real challenge for us. We've got a few new measures in to try and meet that. We have a new discharge lounge, which we've put into the hospital. We've got a complex discharge liaison team and patient flow coordinators, which help bring expert knowledge when we're trying to discharge patients with multiple needs safely. We have a same-day emergency care unit, which has started at the hospital over the last couple of months. This is working really well. It's run out of the old short stay unit, and they're assessing and treating over 100 patients a week. And often the patients may come back the next day, but they're managing to avoid being admitted, which is obviously good for them and good for the hospital. We have the CMDU, which is a service that was set up to treat patients with new antiviral treatments for COVID. So patients who are diagnosed in the community with high risk, such as on immunosuppressants, on chemotherapy, who get COVID are receiving these antivirals in the hospital, and that is preventing them then getting sick and attending and ending up on ITU. So again, that's working very well. And we brought additional point of care testing into ED. So that's testing whereby we can get a result turnaround within about 20 minutes on things like COVID swabs, but also on flu, norovirus, and this allows us to make decisions at the front door as to who needs to be admitted and which area of the hospital they need to go to. So that's, again, working well. In terms of other areas, we're one of the few trusts continuing to do diagnostic work throughout COVID. We haven't stopped at any point doing elective procedures through this wave. We're currently sitting at 92.7%. So that means that of patients who are referred in with a suspected diagnosis of cancer from primary care, they will be seen within 2 weeks. And our 31-day access is, I think, 96%. So cancer target-wise, the hospital is doing well. We're now doing a deep dive of all of our routine diagnostic waiting times to bring them all back to be seen within 6 weeks of initial referral, and that's working across the whole trust, all the different specialities. We have challenges in diagnostics through MRI, CT, and endoscopy, and we're looking to increase the capacity in all of those areas. And one of the sort of key bits of that will be the diagnostic hub that we're looking to bring in at West Berkshire Community Hospital. What's happening at West Berkshire at the moment in terms of our community hospital there, we're doing 3 to 4 Saturday endoscopy lists, so all-day endoscopy on most Saturdays of the month to keep up with the cancer targets and the diagnostic targets. All the services there have resumed with a mixture of face-to-face and telephone appointments, and we're seeing a month-on-month increase in utilisation of the clinics there. We're running extra clinics in all services where we can to help clear any backlogs. There's some space we're providing to help out with the 12 to 15 COVID vaccination programme that BHFT are delivering. And WBCH is going to be one of the first community diagnostic centres in the country to open. So there'll be new MRIs and PET-CT scanning facilities opening at the site later this year. 2 MRI scanners have been bought by the Royal Berks using a £2 million charitable donation raised by the Newbury and Thatcham Hospital Building Trust with the Greenham Trust, the Peter Baker Foundation and the Story Charitable Trust. And that will massively improve capacity, and it will improve patient experiences, stopping patients living out in rural West Berkshire having to travel to the Royal Berks for their imaging. Just a couple of highlight in terms of what we're doing to try and get those numbers back under control. So ENT have done a Super Saturday and did 18 tonsillectomies, cleared all of their backlogs. Ophthalmology did a 2-week waiting list blitz, cleared 315 operations, so just 31 left who are awaiting suitable donor material. And then there's a health improvement program, which we're doing with the University of Reading, 3-year initiative. And they're focusing around health inequalities, prehabilitation, smoking cessation, and maternity outcomes in mothers from ethnic minority backgrounds. We're working well with the independent sector, so we've transferred patients halfway through their pathway into the independent sector if we've had theatre capacity issues to get their procedures done quickly. And we've transferred 2,500 at source to the independent sector where we think that will deliver the care quicker. We've provided mutual aid for Oxford and Buckinghamshire, including ENT, orthopaedics and neurology. Their response to the COVID pandemic has meant that their wait times for orthopaedics and things was very long. So we've provided mutual aid to them. And we're working with the integrated care system to share good practice and offer further support to the acute providers. It's one of the benefits of working at scale across the ICS. Winter campaigns, I'm sure you're all aware of. There were three real main themes: be prepared, encouraging patients to be ready for the winter, make sure they had plenty of their inhalers, that they wouldn't, run out of their medication on Christmas Eve, so that the health system was not put under any more pressure than it needed to be. Choose the right services and see your GP differently. So it's about educating people to use different services, understanding that the triage to, for example, musculoskeletal physiotherapy might be actually better for them and quicker than seeing their GP in the first instance. And those three campaigns have, I think, run well. We've had lots of social media hits. In terms of the hospital site, we're one of the 48 trusts that have been identified in the government's new hospital programme. Building Berkshire Together is the programme we sort of name it, the Royal Berks. We've submitted first phase drawings, strategic outline cases, and we're waiting for feedback to progress to the next formal stage. Progressing a number of projects to place us in a better position to progress. We're looking at a range of options to redevelop or relocate the Royal Berks and develop further to reach an option depending on what comes back from the centre. And you can see on the bottom there, anyone interested, keen to hear about this or be part of the team to design the hospital, there's an email on the slide there, building Berkshire Together at royalberkshire.nhs.uk. And final slide from me, just to say our green plan to reach net zero is get a lot of work going into that at the moment, lots of consultation on that. We're looking to reduce the use of desflurane in surgery, promoting alternative travel options for staff. We've already achieved a lot, replacing 2 miles of leaking inefficient underground pipework and 5 electric staff pool cars. I think I've talked enough, so I'm happy to take any questions. Thank you.
Thank you, Alex. As I think members will be aware, certainly members on Local Outbreak Engagement Board, we're reasonably close to some of the information that's been coming out of the hospital regarding COVID, because I'm a governor, so I have been talking to Graham Sims, the chairman, on a fairly regular basis about performance, and some of your performance numbers aren't surprising me personally, but they may be of very great interest to members of the board and the wider public. And we had a piece on building Berkshire together. Indeed, we had a piece on building Hampshire together as well last time round, and that is something we're keeping a close eye on, obviously, from this neck of the woods, because the location of a acute hospital that serves pretty much most of our population. I know we have a couple of other acutes that we might find our residents going to, but nevertheless, I think Royal Berks is principal amongst them, and therefore the location of that hospital and what it looks like is of great interest to our residents. So I'll now turn to questions, and I have a question from Paul.
Thanks. Yeah, the piece that I'm closest to, I guess, is the hospital discharge piece.
Well, sorry to interrupt, but for the benefit of those who aren't aware and members of the public, just to explain who you are.
Of course, thank you. Sorry. Yeah, I'm the service director for adult social care within West Berkshire Council. And consequently, I'm close to the hospital discharge piece. And I think there's been fantastic joint work, really effective work to make best use of the additional funding which has come from government to support the hospital discharge, the rapid community discharge scheme. And just for context, I think it might be worth pointing out at this time that our anticipation is that funding stream will end at the end of this financial year. So there will be some impact. I guess I wanted to put that as an important kind of context piece, because whilst we have achieved loads, really positive work on that discharge piece, the circumstances will change essentially from the 1st of April in terms of the available funding. So we'll see some changes there, and we'll do our best to manage that.
Thanks, Paul. I guess that was more of a statement than a question.
It's a statement. I'm obviously more than welcome if Alex wants to comment on that comment, but it's extra detail that I think is relevant.
He shakes his head. So
we're aware of that, and we're looking. So the discharge service sits within my care group, and we're looking at what what the art of the possible will be from April in terms of posts that we've put in, as you say, with that funding. We don't anticipate reducing. Most of those posts will stay going forward. So, for example, Jill, which I'm sure you know, Jill Gillespie-Shahabi, who works across the ICS on this. We have no plans for, even though her post is funded through that, for her not to continue. She will be continuing.
Thanks for that. Councillor Doherty.
Thanks for your presentation. Very, very interesting. Actually, quite a positive presentation was how I felt listening to it. And I particularly like the idea of a Super Saturday for tonsils. One of the things I was going to ask was, it is quite a positive picture that we're hearing today. However, I can hear the pressure in the ED, that the increase is coming through the ED. But we hear nationally all about increases in waiting lists and everything else. Where do we see that coming through in the Royal Berks? Because I kind of don't sense it from your presentation, but I just want to get a feel for where that sits within the Royal Berks, particularly for West Berkshire residents.
So I think with regard to the cancer targets and the elective, I think the Royal Berks is in a really strong place, actually, nationally. As you can see by the data that I've presented, where I suppose you'll see slippage is on the 4-hour target in A&E. The Royal Berks have struggled to hit that. We're actually, if you look across the southeast, one of the better performing trusts, but we, like everywhere else, are nowhere near that sort of 90% of hope, wanting to see patients within 4 hours. And that's just about sheer volume of people accessing ED through the front door. When you get beyond a certain point, just in terms of physical space, and you get ambulances queuing, it becomes very difficult to maintain flow through the hospital. And that's why this work that's been done at the back door in terms of the flow out of the hospital into the community is so important, that we maintain and build some of the on some of the success that's come out of that government funding for getting patients out of hospital effectively.
Thank you both. And Councillor Vickers.
Thank you for that presentation. And my question was about accident emergency and whether or not you're getting a lot of inappropriate visits there, i.e. people who should really be attending their GPs, the local surgeries, because that used to be an issue, and then it went down obviously during COVID. And I'm wondering if that's is now becoming a problem, and whether associated with that, although that might not be something you can possibly comment on, would be our concern about local shortages of GPs, and whether that's influencing you in that you're getting more people just coming to the hospital for care.
So the number of admissions through ED has not risen proportionally. So the attendance is certainly high, and that's not translating into higher levels of admissions, although we have brought in other ways of looking after patients like the same-day emergency care unit. I think that there is definitely higher admissions, and you're right, during COVID there was much lower levels of people attending. I think it's very difficult for primary care at the moment, and I can slightly comment on this because my wife is one of the local GPs in West Berkshire, and they are under huge pressure, and they are having huge problems in recruiting adequate numbers of GPs. So I think we have to look for solutions as a system. We have to look at how we can educate people to access right services. We have to do all the things which primary care are doing, which is bringing in non-doctor staff, so appropriately trained physiotherapists, pharmacists to do prescription renewals, and take the work that can be done by allied health professionals away from the doctors and get them just doing the bit that they need to be doing. And I think that is a work in progress.
One.
So I think that's a work in progress. We haven't cracked it yet, but I think it's quite tricky.
Yeah.
Again, thank you both, and thank you for bearing with the interruption, Dr. Athan.
Yeah, thank you. Just before I ask the question, just commenting on Councillor Vickers' question about primary care and the pressures. And I think you're right, Alex. You've mentioned a few of the things that's going on, but in addition, we've had some extra investment this winter through winter access monies to get extra capacity in, so patients are seen in primary care as opposed to kind of necessarily needing to go to the A&E department. So that's been really helpful, and we've used one of the private providers, for example, locally called Livy, and they're doing remote telephone consultations again to help practices and take the pressure off. So lots of different strategies, but it is still, as you said quite rightly, recruitment's an issue and very pressurised. The question I had was around diagnostics. It's excellent to see that the West Berks Community Hospital will be expanded. So there'll be an extra. I just wanted to know. So there'll be an extra MRI scanner there, and then will there be another CT scanner? And in addition to that, what else will be put in there to expand it as a diagnostic hub? And one of the other strategies, and one of the other things in the strategy was about patients at some point having direct access. Let's say for you've got a 50-year-old smoker, not necessarily, they don't need to go to the GP then to have an X-ray. They can, turn up, ask for an X-ray themselves, and access those diagnostics. Is that part of the kind of strategy? And do you know if that'll be coming on stream at any point?
So in terms of what's going in at West Berks, the aim really is to be able to do everything that we can do there at the Royal Berks at West Berks. So there will be 2 MRI scanners. As you know, there's currently a mobile scanner there which can do some scanning but not all. The plan will be to have two fixed MRI scanners and also a PET CT scanner, which is, as I'm sure you know, is a way or a particular technique of CT scanning that you can use to look for cancer that's spread outside of the primary area. So what we will offer currently will be, when this hub opens, is 2 MRI scanners, a PET CT scanner. We already do CT scanning there. We already do endoscopy there, so gastroscopies, colonoscopies. We already have a system whereby if someone turns up there for a colonoscopy and we find a cancer, they will go straight from their endoscopy downstairs for their staging CT scan before they go home. So all the tests are done the day that the cancer is diagnosed. We already do some dermatology minor procedures there. So in terms of the diagnostics, there'll obviously be plain X-rays. There'll be, as you know, there's phlebotomy there. So it will be very, very small, very specialist stuff that will be done at the Royal Berks site for a small minority of people, like nuclear medicine scanning, that sort of thing, which we wouldn't bring into West Berks. But the vast majority of diagnostics that we need will be based at West Berks. Your second question was around, remind me, sorry.
Patients direct, without needing to go through a healthcare professional, for certain investigations like X-rays, I'm thinking particularly, there's a big push around, diagnosing more lung cancer. So people, could they go direct and have a chest X-ray if this ticks certain criteria?
Yeah, I mean, so not averse to that at all. I haven't yet seen any plans of how we would do that. I suspect you'd need to draw up some quite clear pathways around age, around how often they can attend, around risk factors, so that we make best use of the resource that we have. Yeah, absolutely. For a specific group of patients, that might well look much better in terms of getting timely diagnoses. I think that's difficult, isn't it? And it's also about GPs getting direct access to CTs and MRIs in a timely manner. It's all about how you make the best use of the limited resource whilst not introducing unnecessary delay or workload in the pathways. But definitely we should keep pushing this forward.
Thank you. Thank you both. And certainly, I'm certainly aware of some significant spend on CT and MRI that's going into the trust, which is good news. And I look, as you've anticipated, we look forward to the further development of the community hospital. I see no further anyone itching to ask you a question, so I want to thank you for coming to Newbury.
Thank you.
And good to see you.
I just live up the road, so
exactly. Well, yeah, I wasn't going to make that anticipation. I work in the so thank you for coming in, and you are released.
Thank you.
Members, we now move on to the next item on your agenda, which is, as I say, I brought item 10 up, which is integrated care systems. And speaking on this item is Matt Tate, who is deputy lead for the integrated care system, as will be, I guess, if we would like that. Matt, over to you.
Hello, everybody, and thank you for the invite. Can I just check you can hear me okay? Great. Okay, yes, I'm Matthew Tate. I'm the interim deputy SRO for the ICS, range of responsibilities, but including overseeing the ICS development program, which is focusing on setting up the ICB. Now, I'm conscious that last time I think you had Nikki talking through some of the changes in terminology. So noting I've just used 2 acronyms, I will try to step back from that and give the wider descriptions for the rest of the presentation. But please interrupt or ask for clarification if I do go into too many acronyms around the developing world. So I probably just want to make 6 or 7 points building on the presentation you had last time in terms of updates. So I'm sure you'll be aware that the formal establishment of the Integrated Care Board as an organisation has been put back from April to July. So in terms of what that means to those of us working with the programme and the setup, that highlights a couple of risks and a couple of positive elements as well. So the risks around that really are making sure that we've got the right governance, architecture and bandwidth to carry on with the CCGs for an extra 3 months. And obviously ABID is central to some of those discussions, but actually broadly we're already working together in a number of committees in common across the CCGs, and actually as a risk we're quite confident that we can maintain those statutory responsibilities across the 3 CCGs in terms of capacity and governance. The other risk really is around financial complications really of trying to run finances for a quarter of a year, and I'm sure some of the council members can imagine some of the additional complication that brings to the system. So we've looked at the resourcing around that. Again, we're quite confident we can manage that, but it will undoubtedly be a burden. In terms of the positives, it broadly allows, I mean, this was a tight timeline, and it allows more time for engagement and discussion around our structures and working practices. So that's an absolute positive of the delay, really, to give ourselves a bit more time for that engagement piece and understanding, and these sort of sessions to work through the development of the Integrated Care Board. In terms of progress, we obviously have now a chair designate appointed in Javed Khan. I think it was confirmed last time that James Kent has been formally appointed as the chief exec designate. In terms of non-executive members of the Integrated Care Board, that process is now running, and actually interviews are being held today to look at those appointments. And we also hope to advertise this week for the 3 statutory executive roles. So that's the Chief Financial Officer, the Chief Nurse and the Chief Medical Director. So we're progressing those appointments. In terms of the partner member process, we are still carefully working through the best process to do that, and continuing to engage on the mechanisms around that. We have to be very cognizant of the passage of the bill as we work that through, but that's something we continue to engage on. But again, discussions are progressing in a reasonable manner about exactly how that nomination and appointment process works. And obviously the final appointment is for the chair, but so we're working through that link between nomination, assessment and appointment. At the moment, the working assumption is that the Integrated Care Board will still have the minimum membership. So that's 1 local authority partner member, which is we can describe that in many ways, but in some ways it's a NED-like role in terms of bringing that broader sector expertise, not a representative role. And you will have seen, or you may have picked up from the recent discussion at the House of Lords, that councillors are no longer absolutely disqualified from sitting on the Integrated Care Board, but there still is a recommendation and a view that role should be an executive member. But that formal disqualification has been removed at this point, subject to the passage of the rest of the legislation, obviously. On the integrated care partnership, so this is the broader, more strategic partnership model. Again, we are treading carefully in terms of engagement and discussions on the setup of that. That will need to be established on the 1st of July by its founder members, and its founder members will be the chair of the Integrated Care Board and a local authority representative from each of our 5 local authorities across the integrated care system. So again, I suspect we will take a grow and review approach to that, with the founder members being established, and then to work out how we best develop and discharge that function over the first 3 months. We're on the other couple of things I wanted to mention on governance. We are looking to establish place-based subcommittees as part of the Integrated Care Board to support the place model. I fully appreciate that that's a more complicated debate in the Berkshire West system for the 3 local authorities, and actually the word of the use of the word place in ICB and NHS language is not always that helpful, because you absolutely quite rightly use the place narrative for your local authority areas. And so we need to work through, and we will need to work through how those place-based committees operate, and how that builds on the collaboration across what we describe as the Berkshire West system and the responsibilities of the 3 local authorities. But it's an important principle to demonstrate the continuing importance of all our places across the BOB system. And you'll be well aware of the white paper and the alignment of that to the importance of place. And that's, from our perspective, very consistent with the development of the direction of travel. And the last point I really wanted to make is we're starting to think about the process for developing the ICP strategy to inform, the Integrated Care Partnership strategy to inform the Integrated Care Board strategy. So we expect that to be a 9 to 12-month process, and we're starting to look at how we structure that, how we start the engagement processes, linking with health and wellbeing boards, joint strategic needs assessment, and just trying to get ourselves organised around that. And we'll be looking at establishing steering groups with the appropriate representation across the system as we move that forward. I could talk about all sorts of issues around the transition, but I'm hoping that's given you a flavour of the progress we're presently making, and tried to highlight perhaps some of the key issues that might be more relevant for your debate and questions today. But if you're happy, Chairman, I will stop there, and happy to answer questions.
Thank you for that. And I will start, if I may, because I'm probably as close as anyone to this debate about the, in particular, the ICP and its relationship with local authorities, and the PBP, the Place-Based Partnership, Berkshire West, as is currently formulated, and its relationship in this area, because we have 3 local, as you rightly anticipated, 3 local authorities within it, ourselves, Reading and Wokingham. 3 points, I think. Firstly, you, I think, said, in reference to ICP founder members, the chair of the ICB, to be Javid Khan, and 5 representatives from each of the local authorities. Now, if I understood you correctly, that is the first I've heard of that. You'll appreciate that we have been having discussions, the 3, Wokingham, Reading and ourselves. There have been discussions between the leaders and the health and wellbeing members, as it were, depending on which system is operated in that particular local authority, and the chairs of the health and wellbeing boards, if different, about how we interact, in particular with the ICP, because we recognise that the ICB only has 1 local authority rep, and that currently is an officer. So I'd just like a little more flesh on that particular bone, if I may. Secondly, you referred to the strategy, And I'd just like to, obviously, we have just very recently signed off a joint health and wellbeing strategy for the next 10 years across our 3 local authorities, principally within the local authority, but with some overlap, and indeed some overlap up to ICS level. So again, a commentary about how the disparate, and hopefully they're not too disparate, but the strategies that exist within the various place areas, Buckinghamshire, Oxfordshire and Berkshire West, are going to be not brought together, but how the strategy at system level is going to interact. And finally, just to anticipate that, of course, and I fully appreciate this is going to be a major piece of legislative change, because with the formal departure of clinical commissioning groups and the fact that CCGs are referred to in all sorts of bits of statute, but importantly from our point of view, in their appointment of a member to this board, and that member is a statutory appointment effectively, and secondly, for our terms of reference, one of them has to be in the room for us to be quorate. I just wonder whether there is any thought about what might come forward as health and wellbeing board representation from the system or the place or whatever. So there you are, 3 interesting questions, hopefully, and I pass to you.
Indeed, thank you. So I will do my best for those 3. Thank you, Chair. So on the first one, I think it's very So I think the integrated care partnership has always been clear that that's going to be a much broader representative discursive group. You're right, it has become clear. We're starting to receive, as you can imagine, we receive quite a lot of constant updates and guidance. So I was just feeding the latest intel I've seen, which makes it slightly clearer that on day 1 we do need to have the integrated care partnership established with its founder members, and the briefing that I've had indicates that those founder members, I think, which has always sort of been the case, but perhaps this is more explicit, is local authority representation and the chair. So absolutely, that's my present understanding. We have received a bit more clarification recently, which perhaps makes that slightly more explicit in the way I've described it than previously, but that's absolutely my understanding. On strategy, I think you're right. One of the challenges will be the coordination of place-based input into that, and I think that will be absolutely embedded in our process. I think that process will need to do a check on some of the baseline information, and I think you've obviously used a lot of that to inform your health and well-being strategy, and obviously we were aware of the work that you've been doing across the Berkshire West system on bringing that together with Katie and many others. So we will look to build on that. We'll look to build on the strategies of the 3, identify some of the common themes, some of the common challenges we have as system, and where the system can add value to that or impact on some of the issues we've got to work through. That will be the case. So I'm happy to sort of, perhaps I'm sure that we will continue engagement on how we approach that strategy, and I would recommend probably to you, if you're comfortable, for us to have a discussion about that sort of strategy piece and how we align it as part of a future ICS development update in a bit more detail. On the last one, I think that's not entirely clear from what I've picked up and the guidance I've seen to date. I think the importance of health and wellbeing boards in terms of their relationship with the ICP, integrated care partnership, and also with place-based partnerships will be critical. So I think it's probably an area where there'll be quite a lot of flexibility around how we ensure that representation model is reasonable and there is crossover between the 2. But I have not seen absolute guidance on that, and I suspect it's one of those areas where it will be left to a relatively high level of local discretion and local discussion. I hope that's helpful, Chair.
Yeah, I'm just going to be interested in, obviously, whenever you change the name of or move or get rid of somebody that has a legislative status.
Yes.
All sorts of bits of legislation have to be amended. So I will just wait to see what the amendments are as they come through. Andrew Sharp.
Thank you, Mr. Chair. Andrew Sharp, Healthwatch West Berkshire. Matthew, I think the thing that concerns most of health watchers around the country, and in fact Healthwatch England, is that when you look at how the sort of clinical commissioning group structure originally was, with 4 clinical commissioning groups for each local authority area, in fact we had 2 for Reading, with 2 lay members to represent patient interests on the board, we've gone from effectively 8 to 3 lay members. And with the new structure, which you very importantly underlined was the minimum membership, we have 3 very disparate areas in terms of Oxfordshire, Buckinghamshire and Berkshire West. And, you know, West Berkshire starts to feel very, very small in that giant system. And especially with our patient flows going out of the integrated care system area to Great Western, to Basingstoke, etc. Only having 2 non-exec lay members on the ICB board and currently none of the 5 Healthwatch represented on the board doesn't seem to match the sort of exemplar systems being pushed by NHS England and Healthwatch England, such as the Leeds system. So, you know, we just remain concerned that it feels like there's a giant ocean tanker moving along, going to transform the lives of the patients of an enormous area, and actually getting input from the coalface via Healthwatch, who talk to patients on a daily basis all the way through the system, seems a worry. Our jointly funded officer, which was an absolute first in the country, the post has now died on the vine. In fact, the officer involved, who'd been involved with the ICS and in fact the STP, has now left. Hasn't been replaced. There's been no talk of it. We've had no senior officer in Berkshire West for a good period of time, which was always a good post for us to take issues and worries to. Yep. It's starting to feel very monolithic. And, you know, as one of the smallest health watches in the country, banging up against the door of Oxford, an office in Oxford, saying we've got a problem with patients going to Great Western or something, raises huge concerns for us. I know there's some great work going on with Healthwatch England. In our patch, we've been identified as one of the areas that they're concerned about for this sort of very reason. So it's a sort of an appeal really to say, can we go from looking at the minimum membership of various boards and where patients are going to interact to just be a bit more open in terms of how a structure could start that appeared to be more transparent, more open, and actually involve the word patient. The other big concern, which I'm sure Gary may want to comment on this, is how the voluntary sector and health watchers are being lumped together as one group when they absolutely are not. We are a statutory body. They're only to represent patient voice. And this seems to have sort of been lost into the giantness of the whole transformation. So really, it's just an appeal to sort of say, you know, our Health and Wellbeing Board works brilliantly in terms of taking that patient voice to all the partners and actually getting some actions. We've done some amazing work by actually being able to bring that to this forum. And I just don't see this route easily and currently into this giant change of systems. So it's sort of an appeal, and it's also sort of just a mark to just sort of say we're concerned. Thank you.
Okay. Thank you, Andrew. So I take on board your comments and your concerns. I think, and you're quite right to say that we are, you know, the mechanism is on some areas starting with a minimum building, and we need to build that the transparency and the trust around that approach as we move forward. Fully accept that. I think the I think as we grow the ICP, I'm absolutely certain that the Health Watch and patient engagement model will be really important to that. I'm absolutely certain about that, but absolutely accept we haven't outlined that fully yet. So that is developmental. So I can only say that we acknowledge it as important, and we accept the fact that we haven't quite got the model there yet, and that must feel frustrating. So I think we accept that. I think on the how we get the balance between the integrated care partnership and the integrated care board and place-based partnerships, and indeed health and wellbeing boards, that is developmental as well. I can't pretend otherwise that it's not developmental. I do think some of those factors will mitigate some of your concerns about line of sight and engagement, but we will need to work together on that. In terms of the local leadership model, I think we have managed a risk in terms of local leadership in Berkshire West, but we are committed to a role in the structure called a place executive director. Now that will be the Berkshire West place at the moment, obviously, but that will obviously need to link into the relationship with the 3 local authorities and health watches. So that absolutely will proceed and is embedded as a principle in our structure. I'm happy to take away the lumping together comment you made, Andrew. That's not how we should be articulating it or understanding it, because actually these voluntary sector are a really important part of the model, but they are part of the provision model as well, whereas Health Watch operate a particular role. So I'm happy to receive direct feedback from you, Andrew, on where you think that message is coming from, and see if I can course correct that. And I'll also take the broader point about Health Watch engagement across the integrated care system back to Catherine, who's our lead director for engagement across the entire patch, to see if we can strengthen that a little bit. So happy to take those comments away. Can't give you more than reassurance at the moment in terms of some of the models, though, so I do apologise for that.
Thanks for that. And Matt, I'm going to hold you there for a moment, because I think it'll be on the same subject. So I'm going to bring Gary in on the volunteer point.
Thank you, Chair. Yes, I'll keep it brief, just really to underpin what Andrew's just said, because I've heard the same conversations really about wanting to lump in the voice of the public through the voluntary sector. The voluntary sector is the voice of specialisms and delivery, and not the entire voice of the public. And I think it's really important that those things are not conveniently bunched together, and there should be a seat at the table for both organisations. Yeah, thank you.
Thanks for that, Matt.
Thanks, Chair. Matt Pearce, Service Director for Communities and Wellbeing at the Council. Matt, thanks for that. It's just a quick observation, really. Obviously, one of the 2 priorities within the ICS is around improving population health outcomes and tackling health inequalities. So I guess it's just ensuring there's that voice for public health, whether that's at place or at the systems level, and the role for directors of public health. I think that has to be pretty fundamental in terms of the development of the ICS. So I know there's conversations going on at the national level around that, but I think there just needs to be some further thought, making sure that expertise is utilised in that new system. Thanks.
Yeah, I'm sure that Tracy, who unfortunately can't be with us today, would make very much that point. It is, and of course we have an interesting situation in Berkshire West where we have a Director of Public Health for the place-based partnership, but we also have public health embedded in each of the 3 local authorities. So yeah, we make our points, Matt. I'm sure you've listened to them. Hopefully you'll take them away. And
I absolutely agree with the importance of that function, that role in terms of targeting and supporting the inequalities agenda. So but I can't give you a full answer at the moment, but we will continue to consider that. And you're right, in linking with the national guidance and development, that may iterate over the coming months as well.
So thank you, Matt. As I said to Alex, you are released. You can go off and do whatever else you need to do. But thank you for your time.
Thank you. Nice to see you all. Thanks a lot.
Okay, members, we move back to the agenda as it was originally structured, and the next item is item 7, which is membership. Now you'll know that we effectively look at membership as the bodies, so we don't necessarily need to vote on membership. And I just tell you that we asked, you'll remember that we asked for different bodies to identify substitutes so that if a member couldn't attend, there was someone else who might attend on their behalf. And I'm happy to say that Dr. Heike Veltman has been appointed as substitute for Abid. And of course, there is a whole conversation, as we just anticipated, about where the what is currently the CCG representation on this board will go as the ICS comes into being in July. Watch this space. Gail Muirhead is going to be the main member for Royal Berkshire Fire and Rescue Service, with Paul Thomas as her substitute. Lorraine Adams is substitute for Matthew Hemsby, and Emily Evans, welcome Emily in the room, is substitute for Zahid Aziz, and Emily's here as his substitute. So please note those changes. And also note, moving on to item 8, that 2 current members will shortly be leaving their posts. Raghuv Basin from the RBFT, his Director of Assistant Partnerships, is shortly to leave. And I started a conversation with Graham Sims, Chairman of the Trust, about who they will be appointing, and to encourage him to check that they appoint a substitute at the same time. More in the room, Matt Pearce, our Service Director, who you've just heard from, is departing to pastures new. And I said in local outbreak engagement that this would be the opportunity that I could say publicly, and of course I work very closely with Matt in my portfolio, but I will say publicly, a huge amount of congratulations, and congratulations to Matt for moving on to become Director of Public Health in Herefordshire. I think great appointment, and it's a fantastic appointment for them, a huge loss for us. But what I will say is that in particular, and I want to, although this is Health and Wellbeing Board and not Local Outbreak, I do want to reflect the enormous shift of work that Matt has led, been personally involved in, and led in relation to the council's response to COVID. It's been a massive amount of work, and thank you, Matt, I'm sure from all of us, for the effort you've put in and for your membership of this board. Right, we now move on to adult and social care reforms. This is a discussion paper. There were no need for a vote at the end, and I'm going to invite Paul Coe, who's the Service Director for Adult Social Care, as you've just heard, to speak to the item. Paul.
Thank you, Chair. Hopefully you are going to see very shortly the right, apologies, struggling with my instructions here. Right, there we go.
You're
yeah,
in
is that yeah, is that
you're
that's
there
working?
Now.
Great, fantastic. Thanks, Paul. So the starting point for these very significant reforms coming our way was set out in a kind of fairly broad plan under the title of Build Back Better, Plan for Health and Social Care. And then more detail has been added to that in the recently shared white paper, People at the Heart of Care. So those are the 2 kind of key places to look for those that are interested in this area of work. There's also a very detailed policy paper, which is looking specifically at the fair cost of care. So that's of interest if that's your bag. But the kind of the big topic is embedded in that white paper. A little bit of history for those that don't remember. There was a DILNOT report which looked in detail at charging in particular, relating to care costs. And the Care Act 2014 set out the foundations, the legal foundations, statutory foundations, to implement changes relating to charging. But That wasn't taken forward in 2015 when the rest of the Care Act was implemented. Now, I'm sure there are lots of reasons for that, but I do think that affordability is probably a really key part of that decision at that time. So the plans as they are set out at the moment, and it's really important, I think, for me to say that what we've got at the moment is still pretty broad. There's an awful lot of work going on to add detail, add meat. So when we do get, we've started to get the occasional question from members of the public, and we don't have all of the detail that people will want to have. It is emerging. Department for Health and Social Care has a number of groups with partners which are developing all of this detail. So what we have so far, though, I would summarise as saying that we've got this. The funding reform is absolutely central. So this is ultimately seeking to make sure that arrangements are affordable and sustainable for the long term, and social care has been an area where the funding has been a challenge in lots of areas of the country. The white paper in particular talks about specific areas for investment, and I'll give you some detail on that. Those areas of investment are particularly connected, as you'd hope and expect, to what is considered to be best practice. So the white paper has a lot of best practice messages about elements like choice, control, independence, and so on. What I would say, being a little bit miserable about the whole thing, is that choice. We've been talking about choice, control, independence, timeliness, etc., for decades. So it's fair to say that a good amount of the white paper is a restatement of sensible best practice rather than a kind of really seismic shift in what is considered to be good. So some of the detail on those changes, I'm sure most of you will be aware of the introduction of the Health and Social Care Levy based on national insurance contributions from April. The other significant introduction is the planned introduction of the cap on care costs. So this relates to people and the totality of the costs that they will have to pay towards their care during their lifetime. And the figure at the moment is £86,000, and that is anticipated to come in October 2023 for new people. An important distinction there. And the other piece, which is a kind of a bit of a refresh of current arrangements, I suppose, is changing the capital limits in terms of who is contributing what to the cost of their care, week to week, essentially. A really significant intent, and I think this is important, and it's going to be particularly significant for us in West Berkshire, is the intent to shrink the gap between what a private funder will pay and what a local authority will pay for the same care. For example, at the cost of a bed in a care home. There is a gap. It is significant in West Berkshire, and government is saying that is something that it wants to address, and hence the policy paper, which sets out a plan to establish robustly what it should cost to provide care. So a few slides now, which look at the additional specific areas for investment. As I say, is particularly useful, I think, for us because it points to the areas that government is saying these are priority areas. These should be improved. They are good. Let's do more. Unlike the other areas of funding, this I suspect will be principally a kind of bid process for most of this. So plans submitted to say we will do this if you invest X amount of money. So I'll whip through them because I think the detail is available. So extra support to staff, really key. Workforce is a big challenge for us. We've talked already. We talk appropriately frequently about integration between health and social care. This is absolutely key. There's quite a bit in terms of closer work with housing across the system. I think that's a good thing. Housing obviously is extremely important in people's health and well-being. Investment on digitization, so using technological ways of responding to people. making sure that the workforce, not only talking about their recruitment, retention, but also training and well-being, all very much embedded in the white paper. We do a fair amount of this already, technology-enabled care, but again, it's good, it's sensible, it's cost-efficient, and it's less invasive than other models of care. Some important planned changes to the disabled facilities grant, which is a good change, increase in the upper limit, because very rarely, but occasionally, we have people who do need more adaptations than the current cap allows. So that's something that I personally welcome for those rare cases. Additional change in terms of the way the support is being provided to unpaid carers. Again, can't state this significantly enough. Really large group of people doing incredible stuff, sometimes at the risk of their own health and well-being. So it's really critical that we make sure that they get the care, that they get the support they need. Also funding to innovate more widely in terms of the way that we provide support. Okay. So this is where it gets a bit darker, where I say, look, I think there are some, certainly for us as a council, I've got some concerns about the net impact of the plans as they are currently set out, because the changes, the proposed change, the cap on care, the changes to the thresholds mean lost income for the council, and as I say, there's a big gap between what we pay currently, what self-funders pay, and that's going to be something that is going to be a challenge for us to address. So that's been shared with members and officers within the council. To explain a bit about the workforce impacts, in order to count towards the cap, an individual will need something in the plans, will need an independent personal budget set out and approved, agreed by the council, by Adult Social Care. Now, because we have very large numbers of people who organise their own lives, actually, they organise their own care, they get on without it to a very significant degree here in West Berkshire. That means an awful lot of people who currently we don't know of, we don't see, and manage entirely well without us, will need to come to us for something. So the impact in terms of work done by people in my service, but also linked services, commissioning, finance, exchequer, and so on, that's going to be really significant. So that's an area for challenge, essentially, for us. And it is concerning to me, as I say, because we have a pretty self-reliant population locally. There's another kind of potential risk to individuals. So one might say, well, if this cap only relates to new people, then I'll wait, right? And I'll wait until the implementation of these changes. And I'm concerned that there will be some people for whom that wait is not good and healthy. So there is a degree for some individuals of kind of personal risk in this as well. And of course, providers who do an enormous, independent care providers do an enormous amount of work for us, for the local population. They will also have to do extra work to make sure that they account for their costs and can show them so that people can count towards that cap. So that was a whistle stop, but I will stop there. I'll come out and we'll be happy to take any questions.
Before I come to Councillor Stewart, Paul, just one thought, because of course the cap on care costs is the cap on health care, as opposed to a cap on what I might call hotel services. And I just wonder if you want to reflect, before we move on to questions, on that distinction and how that affects the numbers.
Well, yes, it is very significant. I think one of the things that I would say, as I started the presentation, detail is emerging, and is, when I say emerging, what I mean is being worked out. People are crunching lots of numbers at this time. So depending on what you read and when you read it, there is a slightly fudgy kind of message going on here. But so I think further detail will emerge on this. But yeah, as it currently posited, you're right. The cost relates to the care rather than the bare utilities, the core costs of a care home. I think we need to understand that a bit more. And I think the other piece that emerged recently from an approach from a member of the public is those that are currently providing currently an unpaid carer and have had some sort of support, but the individual that they care for has not. Are they new? Are they not new? Again, all of this detail needs to emerge. So, but yeah, it's the reason I didn't go there is because I want to get to the absolute black and white final position. But thank you. Yeah.
Councillor Vickers.
Well, thank you very much for that, Paul. I must say I found that all quite overwhelming, actually. I feel really quite sorry for you with the immense challenge that you've got. And I'm just wondering, what more as a council one can do to support you, as us as members, whether we need a bit more out there communicating with the public. Do we need some workshops? Do we need something? Because people need to understand what's going on. I must say, I'm not personally involved in anything like this, but obviously we all know people that are and the complications that they face. But I just think it's an amazing problem. And, and to find that you're just struggling with whether you're going to have the funds to do what needs to do going forward. Great pressure. I mean, it's lots of good stuff in there. And as you say, it's reiterating things that have been going around and around for years and years. And we all know something has to be done, but you can't do anything if you haven't got the funds. I'm really pleased to see in there, really concentrating on the staffing and the support and recruitment, because we all know, so much is dependent on good care staff and raising the quality and raising the status. But just a general comment on what more can we as members do to support you, and what more communications would that be useful with the people out there to realise what the problems are, and what we all need to do to work together to try and sort of just get some good solutions.
Thank you. I appreciate that. It's very, very, very kind of you to say that. I think the sort of one of the key elements of challenge is that initial announcements felt as if they were saying we're going to resolve the challenge in social care by providing more money, and naturally providers and members of the public will have taken that at face value and said, okay, great, this is good news, things are going to get better. And it's that detail which is now giving us a much more complex picture. So I think the first piece that would be very, very supportive is that when asked, it's all fixed now, right? The answer needs to be, well, hang fire. There's an awful lot still to do, it's more complicated. We will be looking to feed in hopefully a degree of reassurance. We'll be looking to feed in some of our concerns to some work that Department of Health and Social Care and DLUC and others are doing. So I'm very pleased and happy that we're going to get the opportunity to say, look, actually, the way we crunch these numbers, particularly, as I say, in West Berkshire, a place which is pretty affluent and pretty self-reliant, the way we crunch these numbers doesn't give us the same answer that you're getting centrally. So thank you. And other than that, Martha, if it's all right, I'll take that as an offer of support, and I'll come back to you if I find the right way. Thank you.
And Abid.
Thanks, Chair. Paul, just a question of understanding. So is it that local authorities will get a percentage of the new NI levy? Because as we've heard over the last week or so, waiting lists for elective care are going to continue to rise until 2025. I suspect that's probably ambitious, that they'll get back to pre-pandemic levels. There was a massive waiting list problem. And we understand the billions of pounds raised are going to be diverted to deal with that, which is a priority for the NHS. So there's a levy, the funding is going elsewhere.
No, absolutely. I suppose I would say it's a health and social care levy. but we're behind you in the queue. That's probably the summary position that I would put it as I've understood it. So please don't go mad. That's my plea to you as a local authority rep.
Councillor Masters.
Thank you, Chairman. Thank you, Paul, for that briefing. And I am aware of some of the issues that, from the briefings that you and your team have given over the last few months. Not wanting to reiterate, the concerns that you have and the committee have probably got queuing up for questions right now. But you talked about the self-reliance for the community here in West Berkshire and how those, it's pretty hands-off. They look after themselves, that self-sufficiency. And they're now going to have to be brought into the fold, at least on a bureaucratic level, if nothing else. I mean, I would imagine that that's going to have an incredible amount of impact in terms of the burden on your staff and just on a purely bureaucratic level. Is there moves through the LGA and through the commissioning groups, as you mentioned about inputting back to the Department of Health and Social Care? Is that one of the areas that you feel that is important to highlight to the government, that why fix something that's not necessarily broken and burden yourselves in these points? So your thoughts around that and what is being taken at those levels. Thank you.
Yeah, thank you. We've actually spent the last 5 years in adult social care trying to get to a point where we are as light touch as we can be, namely where we provide information, advice, practical support, guidance, and so on, that enables people to crack on and sort their own lives out without our long-term involvement. And we've made huge strides on that, and it does feel like some of that really positive progress is going to be undermined or made less valuable with the approach. I don't want to be too miserable about this. But yes, there's a big challenge. We're going to use, I think technology is going to be really key in this. I think, a lot of us will be used to some kind of technological intervention, which is fairly light touch, but which gives us an answer that we can then proceed with. So we're going to do our best at that. We're a bit behind the curve in some respects, in that we've got plans, but they are, as is often the case with IT projects, can be a bit slow to deliver. In a conversation with the DHSC, they are developing a product, an online product, but they described it as a minimum viable product. So I don't think it's going to be as helpful to us as would be ideal. But they are doing some work centrally on how they can help us to do that kind of counting activity towards the cost. We put it this way: we've scaled the challenge, costed the challenge. We'll be feeding that into the centre, into government, and we'll be working really hard on anything that makes our lives and the experience of service users quick and straightforward as it can be.
If I may, Chairman, can I just follow up? What sort of percentage, in terms of a ratio, the funders that you look after directly, what sort of ratio is that between, the self-funders, and what can, just so we've got an idea of the scale of the impacts, is it an equal number, 50-50? Is there 2 to 1 or,
Yeah. So, and again, that's slightly hard to state because it's slightly, hidden. It's a bit of an iceberg, I suspect. What I can give you is a number that says of the people who come to us asking for some kind of support, how many of those people do we commission long-term funded care for? In the community settings, the hospital's slightly higher for obvious reasons, but in the community, about 6% of the people who come to us with some kind of question or issue end up with a long-term service commissioned by us, 6%. So that means that there's a whole chunk of people that merrily go on their way, successfully go on their way, will need to be brought in, and we will be then commissioning and funding their care and funding at the point where the cap is hit.
Thank you for that. That seems an extraordinary number. Thank you.
both. Andrew.
Thank you, Mr. Chair. Everyone knows this is a problem that absolutely has to be dealt with. But as you sort of highlighted, it does sort of feel for some of our population who are quite capable of almost organising their things, we've now introduced a steeplechase element into their lives that wasn't there beforehand. I'm also concerned that probably people who will really benefit from it may then struggle with having something additional put in place. I wonder if there's any concerns as to knock-on effects in terms of getting people out of hospitals, which, because we've just had the presentation detailing why it's so important that we get patient flow out. And in dealing with some of the people who are sort of on the cusp of this from time to time, anxiety levels are already enormous before we add complexity, ambiguity, and to some extent confusion. So I wonder whether in handling this, whether there's some work that could be done in kind of Q&As with carers groups and things like this. So I know that this is developing as we go, but wouldn't it be quite good to get those, well, but what does this mean? Because as Councillor Bridgman highlighted, this sort of care cap is not really what it seems in terms of probably public understanding of what the care cap is, because it includes some things and doesn't include other things that may confuse the public. So I wonder whether, as this is being developed, whether we've got some opportunities to do some Q&A sessions with carers groups and people who may be affected, and equally the folk who you've said may go, well, I'll hang on until 23, which might have an impact on them and their families. Thank you.
Yeah, Andrew, thank you. I think that's absolutely right. For me, it's probably a timing question. At what point, if I can imagine that some people would be quite frustrated if we turned up now and said, right, we think it's going to come in October. There's a go no go decision in September, so 23, so it might not happen at all. Or we're not 100% sure what. Anyway, long story short, at what point does it become clear enough that a conversation with the local population is really useful in that detail, and we'll work. That's part of the planning process for us, is to get a sense of, right, what are people worried about, and what are the preconceptions that we need to address most urgently. And for me, that starting piece of a cursory read of the press would have said, oh right, adult social care is going to be fixed quite soon. We need to address that.
Thanks. And finally, and by no means least, since she is the executive member for adult social care, I'll turn to Councillor Stewart.
Thank you. Thank you, Paul, and thank you to members of the board for their questions. Paul, you covered the majority of the points that are potentially keeping people awake at night. And actually, you talked about, don't want to get too dark. And there is a tendency for us all to be overwhelmed by this. But I think we have to make sure that we remember that the reason for these reforms and changes is to make positive differences to people that rely on adult social care. And that we are all trying to bring something in and together that will improve people's lives. And I think we shouldn't lose sight of that. Just to add to what Paul has said, we have really experienced officers that understand adult social care services inside and out. So that's a good thing. And those officers are working together as we've pulled together a project team to be able to help to, and they've already started obviously sort of working through the information that has come through. And as Paul said, we've been invited to work with central government and the relevant departments. And we're also working with the local government and association as well to try and make sure that we are going in the right direction, that they are going in the right direction, that they understand the concerns and the challenges that we think, could be seen through some of the the changes that they want to make. But as Paul said, so much is still unclear. Digital solutions, I think, is a really interesting one, because quite often I'm one of the first people to say, well, we can't just put everything down a digital route, because there will be some members, some residents that just isn't practical for and doesn't work for them. But in terms of our own, if you think about within the council, actually some of the digital solutions to help us to manage and monitor the data that we're going to need to do, as Paul talked about, where we're trying to monitor the CAP piece as well. That actually is quite essential, and we have regular meetings. We've got a board this afternoon actually where we're talking about some of those projects and some of that digital piece that we need to do. So that is progressing and ongoing. And then finally, just to, I think you raised a good point, Andrew, about comms and engagement. What I could suggest is that, and I think, Paul, you were right to say that, you know, we need to be sure of what we're telling people, so that we don't sort of cause any more anxiety than is already out there. But what we could do is come back to the board at each meeting if there is new information that we have established through all of these different conversations that we're having. So I would suggest that might be a good route. And then we're starting to get that information out via Health Watch and via other sort of groups that the board members here. I'll stop there. Thank you, Chairman.
Thanks, Joe. That's, I think, it on this item. So thank you, Paul, for that presentation. This is going to be an ongoing story. Members, we next move on to jumping past 10 and 11, which we took early, onto item 12. And this is me presenting the paper on the output of the Health and Wellbeing Conference. I suspect that most of us, if not all of us, were actually at the conference or have had an opportunity to engage in it. And I simply say that, as you know, conference was held towards the end of January. It was open to anyone and we tried to ensure that we got the message out to the community. We had 98 people actually attended, which I think was excellent. And of those, 87 stayed right to the end. So really, you know, I take that as a comment on the graveyard shift as really good news. We're going to show the video that was shown at the start so that it's shown publicly. I mean, it has been available on the Council's YouTube channel, but I think it's useful for us to reflect on what it said and to get it into this meeting. So again, there's some publicity around it. But before we do that, and just come to you, Councillor Vickers, in a moment, just to reflect that out of the back end, I think there are two things that we need to talk about and consider, not in this meeting, but probably going through the steering group to the Health and Wellbeing Board and through the engagement piece. One is what the next conference should look like. I thought personally that having a remote conference worked very well because it allowed members of the public to engage without having to physically come in. But on the other hand, having people in a room does generate conversation, it generates feed, it gets people talking to each other. So there are two tensions there which I'd like to look into. And as I say, I'm not going to necessarily look at them now. And the other is to reflect that we deliberately, obviously, had the 5 breakout sessions lined up with the 5 elements of the new health and wellbeing strategy. And what we do need to do is take away the comments that are in the pack and in the report from those 5 breakout sessions to the development plan and looking at the what we do with that information in order to engage with and inform the strategy and the plan to deliver the strategy that comes out the back end. So I'm happy to take questions to the extent I can or pass them on to officers, but let's or have a discussion. Councillor Vickers.
Thank you very much. Yes, yes, I attended the conference. I thought it was good. I thought the attendance was excellent. What I thought was it would have been useful, and I don't think there was, if for those who were officers, professionals, or representing a group, whether that could have been at the side of their names, so we were clear who was there in an individual capacity and who was there as part of a particular group. I thought that might have been useful. I think my main concern, I thought the video was great. I thought it was a great way to start it off. I suppose my main concern was the breakout sessions. I thought they were, in some way, the most valuable part of the conference, although people learned a lot from the presentations. And there was a lot of information. I was surprised at the amount that came back, which is listed in the report, and very useful stuff. But certainly in my own, it all felt far too short. I think, and we were supposed to have 30 minutes. I'm not even sure whether we had 30 minutes in the end. But in my particular one, we actually had a couple of presentations from some of the professionals there, which restricted even more the amount of time just, people who weren't professionals could contribute. So I wasn't sure whether that was necessary within the breakout group. Breakout group should be for everybody to contribute. So certainly more time in the breakout groups, I thought was important. And also, I don't know how wide-ranging the representation was, how we link in with vulnerable groups out there, whether we give them some special information beforehand, and whether it might be useful to have a health and wellbeing conference just for young people, because obviously they don't come to this sort of a conference, but we all know young people are massively interested and concerned about their own mental and physical health. And just having a conference where they could, focus on the health and wellbeing of young people, I thought might be useful, but all in all, I thought it was good. Great conference, useful having it online. But I agree with the comment that you get so much more out of actually being face to face with other people.
Thanks for that. And clearly, we take away all of these comments along with the comments that were made at the time and the comments you've seen in the report in order to look at them as we consider what to do next time. Councillor Doxey.
Yeah, it was a question really for you, Councillor Bridgman. It's really around the feedback loop. So obviously there's a lot of information there from those sessions, and the stuff I read and I think, well, hang on a second, we do this. Why has someone raised that? So it's really, I appreciate it'll go off into steering groups, but what I'd like to see is, if we listen to people, what's the clear action plan that comes out of that? Does it come back here to us? And how do we get those messages back to the people that actually joined in? The example I would give you is there was something on here around helping people to apply for things online, and was there people that could go out and help? Well, my understanding was we did have, and we've got befriending village agent type of approach commission. So why aren't those people able? And it's how do we connect up some of the stuff that's coming in here, or is there an issue that we're not aware about? And I just would like to see it come back here to understand the points that have been raised.
I think officers will have heard that. We'll make sure that we have that conversation and discussion, take on board what you say, and come back with a reflection on that commentary and ensure that where we think some things, and of course the difficulty is that in a feedback from a workshop, one person may say something and it's reported, and everyone else in the room says to themselves, well, actually, it exists, or this happens, or that happens. But making sure that the general public know through our comms strategy what can be done, what can't be done. So maybe a reflection on outputs from the conference in the comms strategy. These are all things we can consider. Happy with that? You nod. Thank you. Right. Unless there's anything else, move on. So, members, the next item is an important one, but unfortunately, we're not going to be able to really have a proper discussion because, and entirely of no fault of their own, there's clash of meetings, which mean we haven't got a representative from the Safeguarding Adults Board to talk to us about the Safeguarding Adults Partnership Annual Report. Now, this is clearly an important, very important document. It is reflective. I would There was some commentary upon the report in relation to, because it appeared and is on the agenda for this meeting. So I know that there was some press reporting of the outputs in, and particularly the case studies in the report. And I reflect, having not just looked at the report, but actually gone back and looked at the cases on the Safeguarding Adults Board website to look at what they were about and who was involved, that this is a report that covers the whole of Berkshire West. It's the west of Berkshire, not the West Berkshire Safeguarding as a report. So it does include Reading and it does include Wokingham. I think it includes the Royal Borough and Bracknell and Slough. So I think actually it is, although it is the West of Berkshire board, the reports, as I understood them, affect the whole of Berkshire. But if anyone was particularly interested in understanding those very regrettable incidents where there has had to be a full report or a practice learning note, I would invite them to go and have a look at those reports and practice learning notes on the website in order to understand who was involved and what went on. Now, if members feel that there is anything in the report that requires further discussion, then what we can do is bring this back as a discussion paper, and clearly what we would like to achieve is to have some representation from the board here in order to engage in that conversation. That is our difficulty, that simply through circumstance we don't have anyone. So I'll now go to members and we can decide what we want to do. Councillor Doherty.
Thank you, Councillor Bridgman. Obviously, there's some quite big headlines in here that make you sit up and take notice. The 50% increase in the number of safeguarding concerns across the partnership. And I, like you, when I read 50%, thought, oh, until I started to look down into where we are. And you can clearly see that the level of increase, while West Berkshire has had a level of increase of 13%, which is still an increase, it isn't in the same ballpark as some of the other local authorities. However, for me, that raises another question, which is how do we ensure that our residents in West Berkshire aren't lost sometimes? And it's always one of my concerns when we come together as three unitaries. And I know when I was with children and young people on the Children's Safeguarding Board, one of my concerns when we come together is that the impact on and the focus on some of the areas that are having more incidences, you sometimes lose the nuance of what's going on here in West Berkshire. And this report to me was very much a regional report rather than a West Berkshire. And I would like to see us look very closely at the West Berkshire safeguarding adults' concerns and recognising what they do, because I don't feel from this report I can understand enough about what's happening here on the ground in West Berkshire.
And I tend to agree with that commentary, and maybe we will reflect on that when we decide where we want to take this. Councillor Vickers.
Thank you. I mean, I've got two specific questions. I'm asking on behalf of Councillor Alan McCrow. He picked up a couple of issues. I mean, I'll put them, but it sounds as though we might have to possibly come back to them. On page 61, I think it's 1, 2, 3, 4, 5. Sixth bullet point down, it says the performance and quality subgroup investigated the increase in no support, etc., and refers to Reading Borough Council and Wokingham reviewing their recording practices to ensure that they were consistent with NHS digital guidance. And Councillor McCrow is asking, does West Berkshire need to review their processes, or are they already compliant with NHS digital guidance? Obviously, it's not very clear there. And on page 62, there's also a comment that the Safeguarding Board not complying with quality assessment framework because it doesn't have the capacity. I think that's 4 point down. And the question obviously is, shouldn't the board make sure that it has got the capacity? So there were two issues that were raised by Councillor McCrow. I don't know whether they can be answered now, or whether we have to come back regarding those.
Well, I hear those. Officers will note them. I know Paul has got his hand up, and I will come to Paul last deliberately so that he can flesh out anything he needs to flesh out. But clearly, I think we are moving towards a position where we would like to have a paper on this from the West Berkshire angle, and bring it back to the next meeting and seek a representative of the board able to speak about the board generally and more to the point about the West Berkshire experience. Gary.
Thank you, Chair. Yeah, you do have some representation of the board, because I'm the voluntary sector representative for, it is actually West Berkshire, Reading and Wokingham.
Yeah, I was intrigued by that. And indeed, if you look at the reports, there is mention of Windsor, for example. There is mention of Slough in some of the case studies. So it's an interesting mix of reports against a background. And I do understand that there are those, and I certainly attended when I was portfolio holder for adult social care. I was effectively on the board by attending meetings. I think it's more, if I can put it like a chairman level type representation, officer type representation.
Yes, I understand. I understand you meaning. I wouldn't begin to be able to talk on some of the technicalities of the report. Suffice to say, I think obviously with better reporting or easier reporting mechanisms, and that's been improved greatly in West Berkshire, because you get better reporting. The ability to report, the numbers will go up, and that's probably a good thing, because it means we become aware of issues for people that need to be resolved. I will say we've literally just appointed a new independent chair who takes over from Teresa Bell, and we've got Professor Keith Brown, who is a leading professor actually in this very field, and he was a very impressive candidate. We had some very impressive candidates, but anyway, he was head and shoulders, and he's also chairing the NHS England Safeguarding Adults Network as well. So I think we're very fortunate. So if there are new areas that you want to explore, then I think this would be a good opportunity to sort of set out what it is that we want here in West Berkshire. Of course, the resource there is in Reading. I imagine West Berkshire Council making a financial contribution to the administrative role that Lynn Mason undertakes there in Reading Borough. And maybe that needs to be looked at as well in terms of capacity, as alluded to by Martha just now.
Thank you for that. And I'm now going to go to Emily and welcome to her first meeting.
Thank you. Can you hear me all right? Brilliant. I don't know whether you know, but before I took this role at West Berkshire, I was the DCI for PVP in Berkshire. So I've worked in safeguarding for most of my career, actually, across Berkshire. The reason that this is a Berkshire West document is because most of the partners that sit on this cover all three areas. And like for me in my last role, I covered all 6 local authorities, which is quite unique to the rest of the force in terms of Oxfordshire and Buckinghamshire. So it is quite challenging. And I think if you were to try and understand the detail for West Berkshire, you'd obviously have to rely on people from within West Berkshire. Like Windsor, we identified that we didn't have enough cases of like serious case review for both adults and for children. So we decided it would be a good idea to share the practice and the learning from those reviews collectively in Berkshire, because we worked so closely with each other. So if we were to just wait for something to happen in West Berkshire, we would almost be on the back foot, really. And we do probably to a certain extent get less attention because the crime rate is less, the demand is less here in West Berks than it is in Reading, and in some parts Wokingham. But I think, to have that sort of collective view and understanding around the learning from incidents is a good idea. And also what we've identified from more around children, from the sort of the recent stabbings and murders that we've had in Reading. Some of those children have lived in different local authorities, but as we know, criminals don't respect borders, do they? So it's sort of fallen to different areas to sort of have a look at and to sort of share the working together. And we realised that actually even local neighbouring authorities don't work as effectively together as they could do. So I just think it's important just to capture that importance of that shared working. And so I just think it will be a little bit challenging for you to get that data, but certainly if you were to want it from a police point of view, we could get that information from you around that adult safeguarding.
Thank you for that. And I'm going to, Gary, is that a legacy hand or do you want to come back in? Want to come back in? Oh, fine. So thank you for that. And what I'll do is I'll let Paul wrap that, because Paul is as close to this as anybody, I think. Let him wrap that, and then Paul, I'm going to ask you to suggest how we might take this forward in terms of a report to the next meeting, and then I'll see what members think of that.
Thank you. Yeah, I'm not in a position, I'm afraid, to comment on NHS digital compliance with that guidance, but I'm sure we can find out. I wanted to pick up on Councillor Doherty's point about the variation in the numbers. It's very frustrating I'm sure, to members of the board to hear that we don't count everything in quite the same way across the 3 areas. So I certainly, when I talk to my colleague, my team, my safeguarding team, they talk about a significant rise in busyness, activity, and levels of concerns. And the number quoted in there, yes, it's fine, but I think as I say, we're not counting everything in exactly the same way. Just would highlight that Appendix F of the attached report has then links to reports for the 3 different areas. So there is some granular data in there and available. I could certainly ask my safeguarding service manager to come and speak to a future board on the back of that additional annual report. I'm happy to do that. The other piece of assurance I'd like to give is that we do take a quarterly report to corporate board, who is tracking it with great interest, activities on not only safeguarding but also on the deprivation of liberty work and all the rest of it. So the council has very good oversight of that activity and performance. But yeah, we do contribute absolutely to the costs related to the board, the safeguarding adults board, as you'd expect, and see them as absolutely a really good arena to manage this in a joined up way.
Thanks, Paul. Yeah, I will reflect that I recall when tested on this, when I held the adult social care portfolio, that I made it very clear that, for example, if we had a safeguarding issue in respect of a care provider, we might treat every individual in that care home as a case, whereas another local authority might treat the entire care home case as a single case. And that does affect the way the numbers very massively can affect the numbers. So you need to make sure that you're comparing apples with apples and not apples with oranges. So, Paul, could I take up that suggestion that we extract the detail of the West Berkshire piece out of the back end of the report? You've said hopefully it's not going to be too much work if it's sitting there as a piece. Perhaps we haven't drilled in sufficiently, and bring that to the next board along with an officer just to comment on the West Berkshire experience of safeguarding across the piece.
Happy to, and really impressed by your recall there, Graham, that detail.
I try. Members, thank you for that. Let us move on. So, members' questions, as far as I'm aware, we haven't had any. He shakes his head. We then move on to the forward plan. This is again for discussion or information only. You have the forward plan. Now, I did mention when I spoke about continuing healthcare that there is reference in the forward plan to joint funding, health and social care, and Katie Summers and Andy Sharp on the plan for May. I would also reflect from the chair that the structure and updated terms of reference for health and wellbeing steering group are under consideration. That's itemized there, but also that we're looking at all of the committees, as it were, terms of reference, if you can put it like that, and indeed for the Health and Wellbeing Board, for a whole host of subgroups and sub-subgroups, terms of reference, in order to ensure that we all know who's doing what. For one, because I think it is useful to have that sort of aide-memoire and formality around those groups, but also to the extent that it feeds into the health and wellbeing strategy and the health and wellbeing strategy delivery plan. And finally, just to remind officers that we need, regrettably, to move Matt Pearce out of the list. Replacement yet to be advised, but another reflection of Matt's importance, the number of times he appears in these documents. Is there anyone wants to raise anything on the forward plan? No one itching to speak. So future meeting dates. Can't recall if they're in the agenda, but 19th of May, 21st July, and the 21st of July meeting may well have to be rearranged because we have a meeting clash. So please be aware of that. You will be advised as soon as we can. 29th September, 8th December, and then 23rd of February 2023. So unless anyone has anything else burning they wish to bring up, I will close the meeting and ask everyone to stay in the virtual room until we've been told that it's no longer being live streamed.